First question I would like to ask Dr. Podda. Basically, could you please share with us your experience on endoscopy band ligation for those younger children, especially those younger than 1 year old? What are the challenges and options available?
You mean to say when there is a varicose bleeding in a younger child, less than 1 year? Yeah, the option is limited because you can, so the whatever band ligation devices are available now, you can fit it into an adult scope. And once you put that band hood to an adult scope, the diameter become almost 12 millimeter. It is very difficult to push to a infant less than 10 kilo weight. So we need to do endoscopic sclerotherapy. We used to do a lot of endoscopic sclerotherapy before band ligation became easily available. In an expert hand, it is not a difficult procedure, but the problem we can encounter if you are starting with sclerotherapy in a smaller kid with a big varices, the bleeding at the time of sclerotherapy. So there are some technique to avoid that. You need to give intermittent tamponade. Suppose there are 3 or 4 columns of grade 3, grade 4 varices. You start injecting the smaller one so that the risk of bleeding is less. Once you touch the big varix, invariably on withdrawal of the needle, it will bleed. So try to keep the needle in place for a few seconds, and then after withdrawing the needle, you push the scope into the stomach, suck out air, wait for a couple of minutes, automatically bleeding will stop because of this tamponade effect.
All right, thank you. So I also have another question for Dr. Podda from our online audiences. Is gastric lavage still useful and recommended in pediatric upper GI bleeding? And what is the recommended high dose PPI in pediatric GI bleeding? Is there any different in terms of bolus versus continuous infusion? So those are two questions.
Sorry, I didn't get the first question. You need to repeat me, but let me answer the second question first.
Okay.
We don't have any pediatric study to compare the various doses of PPI. We try to extrapolate the adult dose. They said that 80 milligram bolus followed by 8 milligram per hour. You convert it to 1.73 meters square, you can calculate the dose. But whatever pediatric studies are available, they recommend 1 to 3 milligram per kilo of omeprazole over 1 hour infusion. So you give it as a bolus twice daily, not a continuous infusion. But adult studies have clearly shown when you have a endoscopically high risk varices, you have high risk stigmata of high risk, there you need to give IV infusion of PPI, especially omeprazole, for 72 hours. What was the first question? Sorry, I missed that.
Oh, yeah. So do you think that if it's useful to perform a gastric lavage, that means to insert an NG tube and do a lavage in upper GI bleeding?
That is a controversial issue. See, in adult studies, they say, if you see the recommendation of Baveno and the American College of Gastroenterology, they get away with this rise tube lavage. They say there's no point because there is randomized trial has shown whether you do the rise tube lavage or not, outcome is not different, risk of bleed is less. But in your day-to-day practice, you will agree with me, the lavage gives you very important information, whether bleeding is ongoing or not, that you can assess. You can clear the stomach before endoscopy, and if you get the bilious fluid, that's reassuring. Now, question of clearing the stomach before endoscopy, in adult, they recommend erythromycin injection. One shot of injection erythromycin, 30 to 45 minutes before endoscopy, that will clear the stomach. Now, we don't have that recommendation in pediatric, and in many places, injection erythromycin is also not available. So in such situation, probably lavage is going to help you to clear the stomach and visualize the lesion better.
Sounds good. Thank you very much for your answer. So let's move to a question for Dr. Wu. Actually, it's a comment from our on-site audience, Dr. Ariani from Indonesia. She also said about foreign body ingestion, that she would like to raise an awareness on the ingestion of water beads, which is often used in sensory play nowadays, and it inflates, and they also have several cases that need surgery due to ileal obstruction. So do you have any experience in water beads ingestion in children? And what would you recommend as a way to minimize the ingestion and also to remove the bead itself? Thank you.
I'm sorry, I do not have the experience about water bead.
For the water beads, yeah. So yeah, do you have any experience in water beads ingestion in children and the removal of the water beads?
I'm sorry, I do not have the experience about water bead ingestion.
Yeah, and do you have any experience in removing the water beads yourself in children? And what is your recommendation on removing the beads?
Water bead ingestion is relatively rare in our practice, but for me, maybe it's common, such as other footballers.
Yeah, okay, thank you. That's okay. So I think that it's like an inflatable objects, and we need to maybe raise an awareness in some part of other countries here, because there is a higher incidence for the children in especially Indonesia. All right, thank you. And what about let's move to Dr. Tui questions. Which organs or which types of bleeding would you recommend to use a cap to control bleeding?
Normally, this is a good question. One, the benefit of the cap is at the bow, do not bow, at the ankle, supradural ankle, and also the high-list curve, because the benefit of the cap is make more stable mucosal facing the endoscopy. That three areas are very important. The second one is if the organ moving so much, you need the cap to fit. That's the benefit of the cap. And also the cap, we have to try the short cap and the long cap. Select the cap, depend on the situation that you face. And the third one, the size of the cap, depend on the area and the age of the patient, that you can select the diameter of the cap as well. So I think the cap is a very good one. Right now in Japan, mostly recommend to use the soft cap. Soft cap, that the good one in terms of minimize mucosal tear. If you're not familiar with the cap, be careful if you use a hard cap. Maybe you clear the mucosal tear as well, complication from the cap. So right now, recommend to use a soft cap is the new model, especially in Japan. And I think so maybe worldwide will launch this soft cap.
All right, thank you very much. So I think this is our last question for Dr. Podda. What is the cutoff age for omeprazole drip? Can we use it in patient at 1 year of age? Do you have any thoughts on the continuous drip of omeprazole? I think a lot of our online speakers are interested in the omeprazole continuous drip, actually.
I already said the same thing, that in pediatric practice, we don't have that recommendation what is there in adult of 80 milligram bolus followed by 8 milligram per hour. We tend to convert the same dose in body surface area dividing by 1.73 meter square. However, the pediatric recommendation says we can use omeprazole 1 to 3 milligram per kilo over 1 hour bolus.
May have some
Yes, sir.
some more comment about the cap. So
Okay.
if you use a rubber band, I recommend to keep the cap of the rubber band. That's really, really good. Free of charge, you can use it. If you, for example, if you use the Cook company is hard cap. If you use Boston rubber band, you can disconnect the chamber out, and Boston provide the soft cap, the tip, the rubber one. That really, really good one. If you use Boston, please keep it, not throw away. It's free of charge to attack. This a benefit. Thank you.
Sounds good. Thank you, everyone, and all the speakers for a wonderful talk today on the first APPSGHAN endoscopy masterclass.